Hello, my name is Enos and welcome back to my channel. This is Work and Wonder. On this channel we talk a lot about the mental health nursing OSCE. So if you're a candidate and you're preparing for your mental health nursing OSCE, then this is the right channel for you. Today's video is going to be very short and it's going to be about the assessment station. In my last video I spoke about the likely outcomes if you are assessing a manic patient. I've taken into consideration that we will be using the recovery model of care, which clearly states that every patient should be treated as an individual. So these outcomes that I'm giving, you have to bear in mind that it depends on the kind of patient that you are meeting. But then mania is mania and depression is depression. So there are some symptoms that cut across that you cannot take away, and it is based on these signs and symptoms that you are likely to get from a patient who is depressed with suicidal ideation that have come up with these likely outcomes. Usually most of the candidates, they are able to do the assessment, they ask the patient the questions, the patient is able to answer, but at the end sometimes some of the candidates are confused as to the specific current risks and then the specific problems that these patients have given out, and at the end either they leave some of them out or they don't even remember what the patient said, or they are not able to put them in the right category in terms of risks. So we'll quickly go to my PC and then we'll look at some of the likely outcomes. And remember, we are using the recovery model of care. Areas around non-adherence to medication, we are looking at living situations, we are looking at current risks, we are looking at just daily life activities like sleep, like nutrition and all of that. So first of all, let's look at sleep disturbances. So with depression and suicidal ideation, usually this is one of the problems, or this is one of the current risks that you are likely to identify, which is sleep disturbances. Either it could be insomnia, whether it could be hyperinsomnia, or it could be fragmented sleep. So either the patient is not sleeping at all, the patient is struggling to maintain their sleep, or they just sleep too much. In any of these cases, this will impact or worsen their mood, their cognitive function, and then increase their suicidal ideation. So if you have a patient that has depression and has not slept for the past 3 days, this could significantly impact on his mood, and it can easily make them have suicidal ideation, because usually they have a lot of things going through their mind because they cognitively they are not settled, and this can instigate thoughts of self harm. Then we can look at nutrition and then hydration. Here we can also look at poor appetite, weight loss or gain. We can look at dehydration, we can look at malnourishment, and then nutrition deficiencies can exacerbate like fatigue, low mood, and then medication side effects. So if they are not eating very well, then even in terms of taking their medication, it can affect them. It can also affect their level of energy, and then they can easily become fatigued because they are not really getting energy from anywhere. They are not eating, so they are not really getting energy from anywhere, and then this can also drift them into low mood, or it can easily drift them into low mood. Then under medication adherence, we can also look at non-adherence, and usually non-adherence is either due to the side effects, it can be due to the stigma, it can be due to forgetfulness, or even lack of insight. So these are some of the causes of non-adherence. So the patient might be non-adherent, but then what is making the patient non-adherent? It could either be the side effect, and as I said, the stigma. We know that most psychotropic medications comes with putting on weight, and usually people don't want to put on weight, or people don't even want others to know that they are on psychotropic medications, or they can forget to take them, or just lack of insight. They don't actually know what the medication does for them, so they can end up not taking their medication, and this can increase the risk for relapse, of course also worsening the depression and then higher suicidal risks. So if you are not taking your medications, because these are medications that are able to settle you, that are able to put you straight forward, or that is able to make you think through things, just balances the chemical neurotransmitters in your mind. And then if you are depressed, it kind of brings you up there, but then if you are not taking it, then definitely this can worsen your case. Then we can look at the key one, which is suicidal ideation. So here there could be active or passive suicidal thought, history of self-harm, or access to means. So here, usually if you have a patient that is undergoing depression and has suicidal ideation as well, either they've tried to self-harm themselves before, or they are trying to now self-harm, and then these thoughts can either be active or passive. When it's active, it's more or less like it's always there, and then they are likely to act on them. With a passive one, it looks like it comes and goes, comes and goes. That is why when you get to your PHQ9, where the question 9 that has got to do with thought of self-harm, you have to explore. You have to ask them whether they are having thought of self-harm, whether it is active or passive, how often does it occur, and when it occurs, what do they do? Do they intend to act on it? Do they even have a plan in place? You know, all these are relevant questions that you can ask around risks for self-harm, and then you'll be able to get more information that you can work with. Here, there could either be increased risk of crisis, then hospitalization, or self-inflicted harm. All these are impacts on recovery. And then the last one that we will look at, last part one that we'll look at, is social isolation and then support system. Remember that with the recovery model of care, there is a part of it that talks about relations. Relations has got to do with the patient relations with his family, with his friends, with any significant other that plays a vital role in their life. So if they are not able to maintain this relationship, it leads to social isolation, which lack of social interaction, withdrawal from family or friends, no support. So at this point, if that is the case, then you should know that they'll be feeling of loneliness and then hopelessness and then reduced coping ability as far as this particular patient is concerned. So anytime you are doing your assessment and the patient talks about isolating himself, he or she not wanting to associate with either friends or family, then you should know that this can easily lead to loneliness, and then loneliness can lead to ideations, which can even also lead to suicide, lead to suicidal ideation as well. Then you can also have substance use and risky behaviors. So sometimes when some people are depressed, they resort to either alcohol or drug use, self-medication, or even impulsivity, which is a key area. So here you also have to identify whether they have resorted to any form of substance misuse, because once there is substance misuse, this will increase the depression severity, impair judgment, and then higher suicidal risks. Definitely there's a link between drugs or alcohol use and then depression. The more they take it, then the more they drift into depression, and then the more they begin to think about having to end it, or start to think about self-harm ideas. Then we can also have financial and then occupational stresses. So if you look at the candidate notes that will be given you, there's a part that talks about living situation. Living situation, you would have to explore around these areas to see whether even their finances also affect their mental health, because some of them, the cause might stem from being unemployed, they having financial difficulties, work-related stress. All these are things that can make them feel hopelessness, reduce access to resources, potential housing instability. All these are things that can contribute to the severity of their depression. So when you are doing your assessment and then you get to the living situation, try and assess these areas. That is why if we look at the social history, there's a bit of it that usually talks about what they do, whether they are teachers, whatever it is. Try to explore around that to see whether they are still into whatever job they are doing, or they are not even into it again. If they are not into it, what happened? And then whatever happened, is it impacting on their mental health or not? You have to assess all these things because they are very relevant for this particular depression and suicidal ideation that you are assessing. Now, let's the very last one, which is engagement with mental health services. So poor engagement is due to distrust, stigma, or lack of insight, which will reduce the access to necessary care and worsening symptoms. So usually some patients, they just don't want to have anything to do with the mental health, mental health services. Some of them, they don't want to be in hospital. That is why here sometimes if you have people that are undergoing mental health issues, they will refuse mental health services, and then they would have to be assessed and probably sectioned or put under any of the sections that will allow mental health professionals to treat them. So ideally, if you assess about 90%, say about 90% of patients, you have about at least 40% or even 45% who don't want to be in a hospital. But then, in the situation in the UK, it doesn't have to be you don't wanting to have access to mental health services. It has got to do with your safety and then the safety of others. So if assessment is done and then it is realized or it is identified that you are at risk to yourself and then the community at large, then you will need to be sectioned under any of the mental health sections, whether a section 3, whether a section 2, whatever the section is, and then of course that will allow for treatment to commence. So there needs to be that willingness to engage with mental health services. So you also have to, that's why at the latter part you have to ask them if you are suggesting admission, you have to ask them whether they consent to that particular admission or not. And if they consent, that is a good thing. If they don't consent and then you still feel that there is that risk there, that if you allow them to be on the community, it keeps on increasing, and that will not be safe for the patient and then for the the community, then you need to involve a crisis team who would also assess and possibly section this patient under a mental health act. So these are basically overall the likely outcomes that you should expect when you are assessing a patient who has depression and suicidal ideation. This is very, very important that you take these things into consideration, and your candidate note and then your PHQ-9 in depression and suicidal ideation, you make sure that you use them, because if you use them very well, then you will be able to come up with some of these likely current risks and then problems. Once you get the current risks, it is very easy for you to identify some of the nursing problems that you can easily use in the next stage of the station, which is the planning station. My name is Enos and this is Work and Wonder. If you've not joined my WhatsApp group where a lot of discussions on mental health, nursing or ski goes on, you can find a link in the description. And then I also have the links to my API booklet, which has scenarios on assessment, planning, implementation and evaluation, as well as my skill station booklet, which also has a lot of scenarios in all the 6 skill stations in the mental health, nursing, OSCE. The link will also be in the description below. Please make sure you subscribe to the channel, turn on the notification bell, and then anytime I upload a video you'll be notified, and then you can come here and take a look at whatever video that I have uploaded. My name is Enos and this is Work and Wonder.